So first of all, I want to welcome everyone. I'm Sue Etkind from Eastman Cares, and I have a wonderful education committee that's helping with all of this, and that's Sally Wood, Dr. Ken Dolcart, and Elise Kendall. So I thank them for all their help, and Lori McClory. Given that this is our first seminar, we had no idea what we were doing, so hopefully it's going to go well, but I thank everyone for that. I also wanted to say that relative to Eastman Cares, I want to let you know about a couple things that you may or may not know about. One is this, which I hope you can see. This is our local community, this is our resource guide, and we have just updated this. So this is available in the entryway at South Cove, or we will also be giving you an email address. You can also email us and ask us for a copy of that. The other thing that is new, relatively new anyway, is what's called the eCares Connection. And basically that is a daily, weekly, or a monthly check-in service. So essentially someone can call every day, every week, every month. And it's really for anyone at Eastman who wants to talk to someone else at Eastman Cares. And we have some people who have volunteered to provide that service. So it's not just people who are living alone here in Eastman, in Eastman, it's anyone. So again, that is an email you can send to us if you know of someone or if you yourself think this would be a useful service. So we would really appreciate that. Again, we're going to show you the address to use on the last slide that Paul shows. Some of the rules for the webinar is different than the normal Zoom meetings. For one, as you all know now, you're all muted and there is no video. So the only people you'll see will be myself as I do all this stuff and Paul, the speaker. That being said though, there is still the opportunity, of course, for questions and answers. So at the bottom of your screen, you should see a Q&A, usually bottom of the screen anyway. And that is where you will put in any questions that you have. Now, Paul's going to have, as he goes through his talk, slides will come up periodically whether there's any questions. So as Paul goes through his talk, if you have a question, just put it in the Q&A. I will be looking at all those Q&As so that I can see if there's like similar questions or be sure that we get everybody's questions. So it's a little different. You can still use chat, but I would prefer that you just use one thing so that I don't have to look all over the place. And that would be the Q&A. So again, it's a little different than a regular Zoom, but it's a lot more efficient from our end. So the other thing is evaluation and feedback is very helpful. We want to know what else you'd want to see. We want to know how we did. And so again, that will be that email that you'll see on the very last slide. So please, we are welcoming your feedback. And finally, this is being recorded so that it will be available. Lori will make it available after we are done, and I will let you know how that's going to happen. Okay, so the COVID-19 seminar series we have put together. It's actually, I think we're into March, I think now, in terms of scheduled speakers. So I wanted to let you know, though, that our next speaker is on November 20th. It's the role of the WHO in a pandemic and current global epidemiology. It's going to be done by Alan Schnur. He has had a career in international health. He's a retired WHO disease control specialist involved in all kinds of disease outbreaks really all over the world. So we are really looking forward to hearing him same time, November 20th, and we'll send out the link for that. Now, finally, for this talk, we have Paul Etkind, who's going to talk about the history of pandemics and the current epidemiology of COVID-19 that changes on a day-to-day, hour basis. Paul is a retired public health epidemiologist who concentrated primarily on infectious diseases at the local, state, and the national level. He has a master's and a doctoral degree from the School of Public Health at Yale. His focus was on infectious disease prevention and control and emergency preparedness. He's had experience with the Massachusetts Department of Public Health, the Nashua Department of Public Health, the Association of County and City Health Officers, the Association of Schools and Programs in Public Health. And he has currently lectured, and he's doing a course right now actually at Dartmouth at Osher, as well as at Adventures in Learning at Colby Sawyer. Hasn't just retired and done nothing for sure. He's done some contract work relating to TB. He created some Zika educational resources. He looked at ways to teach epidemiologists how to write professionally. And I think, as everyone knows, he's currently on the healthcare committee here that are planning and monitoring our strategies in terms of how to deal with COVID and the amenities here at Eastman. So on that note, we welcome Paul, and as I said, just put your questions in the Q&A as we go along, and we'll take care of them. Thank you, Paul.
Well, thank you very much, Sue, and thank you to the committee for the invitation to come and speak, and also thanks to each of you for your time. And I hope that whatever I say, whatever information I have to provide will be worth your time. So let me share the screen and bring up my slides. Okay. Okay. Well, thank you. I ended up with a slightly different title since I was starting out talking about history. I thought a history of pandemics, and a history of COVID-19 through yesterday. So just as I often do, a little bit about vocabulary. Outbreak and epidemic are often used interchangeably. They're both characterized by an increase in the number of cases of a disease or a condition beyond what would be expected in a defined population during a specific time frame. Outbreak is often used for highly localized events. Epidemic is frequently used when the event is more widespread, either numerically or geographically. But they're often used interchangeably. Please note one important distinction. These definitions are not restricted to events with large numbers. If we had one case of polio in America, that would be an epidemic because that is way beyond anything that we now expect to occur in America. So a pandemic is basically a global epidemic. And there are several characteristics of pandemics. They're often caused by a new pathogen or a new strain of an existing pathogen. This pathogen has not circulated among humans in a long time, if ever, and therefore little to no immunity exists in humanity. Pandemics are also a social as well as a health crisis, and this is very important, and I'll be dwelling on this throughout this talk. Pandemics often create social disruption, economic losses, and general hardships. And as you go through the daily paper, you'll see how true this is during this time of COVID. The origins of most epidemics are zoonotic, or they are pathogens that are usually found in non-human animals. There's anything that will increase a host animal and human interaction enables the possibility of crossing the species barrier. So this pathogen ultimately may be also able to infect people. And the true pathogenic potential exists when that pathogen can then be transmitted from person to person. So what can bring this on would be interactions between wildlife and domesticated animals, such as swine, poultry, horses, etc., or interactions between wildlife and humans through hunting, butchering, and consuming bushmeat, which is usually defined as culturally relevant forms of food that are hunted in one's native land. Or it could be ecologic disruption of new territory that humans are moving into for logging, mining, or agricultural purposes. So here's a list of emerging infections since 1951. This is one of two slides. Most of these are zoonotic diseases. Most of those are arthropod-borne diseases. But you can see that as we have been changing the ecology, as humanity has pushed into more and more remote areas, we are encountering more pathogens which are able to infect us and create disease. This is the second one, and you can see since the new century, we've had monkeypox come to the central states of the United States. We had the sudden acute respiratory syndrome, SARS, H5N1 flu, the H1N1 pandemic flu in 2009, Middle East respiratory syndrome in 2012, Zika virus in 2015 that came into the New World, or the Western Hemisphere, whichever you prefer. And now in 2019, we have the SARS-CoV coronavirus 2 virus. The SARS and the MERS are also coronaviruses. So most of these zoonotic pathogens are not initially well adapted to humans. They emerge as sporadic spillover events, sometimes called stuttering chains or viral chatter. They're mostly short-lived localized outbreaks, rarely identified for what they actually are. The danger is that these stuttering chains or this viral chatter provides opportunities for adaptation to spread among humans. And this increases the risk of pandemic capacity. Pandemics are most likely with pathogens that are transmissible from person to person. These pathogens become sufficiently adapted to humans to be able to cause long chains of transmission or person-to-person transmission. Geographic spread is no longer constrained to a particular habitat range of a particular animal reservoir. So the risk of spread is affected by the characteristics of the pathogen. How is it transmitted? How easily is it transmitted from person to person, pathogenicity? Virulence is how severe is the illness. And genetic plasticity is how capable is this pathogen of adapting further to humans such that the transmission is increasingly easy. And also, it may be that what starts out as a very severe illness ends up being more of a mild illness, which from an evolutionary standpoint makes more sense for a pathogen to not kill its host within a short period of time. There are a number of population level factors here. The population density is the first one. And it's really quite remarkable to look at the human population of this world. And between 1750 and 1950, we went from approximately 1 billion to 2 billion people on this planet. From 1950 to 2000, we went from 1 billion to 6 billion people. By 2050, it's estimated, barring some catastrophic event or events, we may have 10 billion people living on this planet. More and more of those people are moving to the cities. Right now, I think 6% or more of the population are in megacities. These are cities that are at most Tokyo with over 30 million people, and down to a number of cities elsewhere in the world with 10 or more million people in them. So these cities are growing very fast, and frankly, they're growing without a whole lot of planning. So there's not much in terms of an environmental health infrastructure to make sure that the sewage is taken care of, other wastes are taken care of in an appropriate fashion. There's going to be tremendous crowding, which makes it very easy for particularly respiratory-borne pathogens to be transmitted from person to person, and so on. So we are developing our world without a plan, so to speak, and in doing so, we are increasing the capacity for other pandemics. Social characteristics are various inequities, such as poverty, comorbidities, nutrition, the existence of marginalized groups. These folks have, they're characterized in ways, and we see this in the United States with less job security, folks with less access to health insurance, less ability to work from home, less access to paid time off, people who have less access to child care services, people who have less likely to have financial reserves, who maybe they're paycheck to paycheck, and having something like COVID-19, it's easier to become homeless. And one of the other factors we're seeing here is that children of the poor, of the disadvantaged, are less capable of being able to have the kinds of technology available to them so that they can go to school virtually. There's a susceptibility to infection with, as I said, with any new pathogen, very few people have pre-existing immunity. Everyone is susceptible, and personal characteristics of their underlying health may exacerbate illnesses so that they're more at risk for severe illnesses and possibly death. Patterns of population movement throughout history. People have tried to move away from the cities and gone to the countryside. Well, who can do that? Well, it's usually the rich or the more well-to-do. And we are seeing population movement here in the Upper Valley. Just look at our COVID-19, just look at the real estate market is incredibly hot. Things do not stay on the market, they're being snapped up. People are moving here. The Grantham Village School has, I think, between 30 and 40 new students who were enrolled this year because folks have moved here. And folks who are on the listening to this, who are Eastman residents, you know that come April, we already had a summertime level of population here. People came up here, and who can blame them? Why not be here to try to ride this out rather than be in Manhattan or the Bronx, or not to disparage Manhattan or the Bronx, but any large city, people look to get out. And then there's the issue of the robustness or not of the medical and public health infrastructure, the ability to conduct surveillance and have response measures. So these are some of the factors that make for more dangerous times. So are there any questions? Sue, do you have any questions yet?
Not so far.
Okay, well, then let's move on. You know, you can ask questions on this section at the end as well, or we'll have an opportunity to offer you, if you email your questions, then we'll be able to get a response that way. All right, let's talk about a little history. So we'll talk about smallpox, plague, great pox, which was actually syphilis, which was even more feared than smallpox. Just by giving it the name, the great pox, to imagine how frightening syphilis initially was. We've had 6 waves of cholera, the Spanish flu. We've had 3 flus, the Asian flu, Hong Kong flu, and in 2009, swine flu. HIV/AIDS is a pandemic that's currently underway, and presently the COVID-19. So I'll talk briefly about each one of those. The smallpox, from evidence of its existence, goes back to the 3rd century before the Common Era through the 20th century. This has killed untold millions. It has hastened the fall of the Roman Empire. by decimating the armies, killing the aristocracy and the civic leaders. It has destroyed indigenous populations and cultures after being introduced by either military invaders or uh, uh, other sorts of invaders, colonists from other parts of the world. So examples of populations that have been destroyed through smallpox introduction have been the Aztecs, the Australian Aborigines, and Native Americans here in our nation. Smallpox is estimated to have killed about 400,000 people per year in Europe during the 1800s. It's estimated to have killed 300 million in the world in the 20th century. The first vaccine ever created was created to combat smallpox. This is also the first of only 2 diseases ever to be eradicated. The last naturally occurring case occurred in the Horn of Africa in 1978, and the World Health Organization declared it to be eradicated in 1980, 2 years of no subsequent cases. Now, there are 2 laboratories in this world that continue to have smallpox in their storage areas, in their freezers. And there's actually a very profound philosophical debate as to whether these should be destroyed or they should be allowed to remain in captivity, so to speak. The first is at the Centers for Disease Control in Atlanta, and the other is in a national laboratory in Moscow. The plague of Justinian. This is the traditional plague, bubonic plague. It originated in northern India and China and reached the Byzantine Empire in 542, while Justinian was the emperor. Therefore, as it happens to all politicians, when something happens on their watch, often it's their fault. If something good happens, then they're responsible for it. So this was the plague of Justinian, which killed millions. The outbreak was linked to a preceding decade of dramatic climate changes. There were lower temperatures, less sunshine, less food produced, which produced great social upheaval. Refugees throughout the world moving around looking for better places to live, better places to farm, to hunt. It was a time of wars. The Roman Empire was fighting the Ostrogoths in Italy, the Vandals and the Berbers in North Africa, the Franks, the Slavs, and other tribes throughout Europe. And the movement of refugees and armies were accompanied by rats and fleas. And so it just continued to spread. And in places where the social infrastructure was destroyed, there was very little in terms of public assistance for anybody. Ultimately, this robbed the empire of its soldiers, its farmers, its trade, and its civic infrastructure. There are estimates that about 25% of the population was killed. 25 to 50 million people died as a result of this particular plague. Now we have the Black Plague, which was it took only 4 years for it to proceed around the world, but this was also a devastating event. It began in Asia and traveled to Europe via the trade routes. And this is sort of out of a horror story. 12 ships from the Black Sea arrived in Sicily, and most of the sailors on these 12 ships were dead. Very shocking to people from the port who went out there because the ships were not really sailing, just very erratic, and they find that they were being manned by dead people. Over the next 5 years, it killed about 20 million people in Europe, which was between 1/3 and 1/2 of the population. It took Europe about 200 years to regrow this population. Wars ended from the lack of armies. The feudal system collapsed. The church seemed powerless, and therefore its influence began to diminish. There was widespread famine, migration out of the cities, and revenge was taken on minorities. This happens repeatedly with diseases and with pandemics. We look for somebody that we don't like, and we blame it on them. Unfortunately and shamefully, I will say that the COVID-19 has been called in some circles the China virus. And I'll show you and talk about a few other examples of being able to get back at our foes through diseases. So let's see. This gave rise to one of the positives is a new order, a new social order came out of all of this wreckage. And it gave rise to the Renaissance. And there was a broader mercantile class as well as broader civil authority. This is an example. This is a 1882. This was from a magazine, a San Francisco magazine in 1882. 3 ghouls. If you can read the sashes on them, malarium, smallpox, and leprosy. And there is a sash being carried by the leprosy ghoul that says Chinatown. So it's blaming these diseases on the Chinese, on their strange ways, on their strange food, and just something that people thought was intrinsically natural to the Chinese. So this is an example, one of many that have happened throughout the history of diseases as well as pandemics. Now we're going to talk about the Great Pox, and this was syphilis, and this raged through the world initially, roughly between 1494 and 1520. This is a picture of the organism that causes syphilis, the Treponema pallidum, and it is sometimes referred to as the carnivorous corkscrew. The origin is unknown for sure, but there is good evidence, and the prevailing story is that this is essentially a gift of the New World to the Old World. And it came back to the Old World with Columbus and his sailors when they returned from the Caribbean. In 1495, it was first recorded, the disease was first recorded among soldiers of French King Charles VII during the invasion of Naples in the First Italian War. Charles VII wanted to have a port available to him that was closer to the Middle East so that he could get there, and he and his armies could get there easier or more easily for the Crusades. And it was called, ultimately the name was called syphilis or the Great Pox, which you can compare it to smallpox. As devastating as smallpox was, that is how much more syphilis initially was feared. The symptoms were painful and repulsive, initially genital sores, followed by foul abscesses and ulcers over the rest of the body, and it's severe pain. This was not as deadly as plague, but extraordinarily debilitating and fearsome. Both armies were mostly mercenaries, and they included Spaniards. After conquering Naples in 1495, Charles's army relaxed with an extended campaign of debauchery. The French forces were debilitated by the disease. Ultimately, they had to retreat, and they returned to France, where they disbanded, and the mercenaries returned to their respective homelands, bringing the disease with them. By August of 1495, the disease had spread to France, Switzerland, and Germany. Pope Maximilian stated that nothing like this disease had been seen before. This was obviously punishment from God for blasphemy. By 1500, the disease was extant throughout Europe. It had made it to India. By 1520, it reached Africa and Asia. Subsequent generations of new infections were milder than its first appearance, and it became more like the disease we know of today. But we go back to the theme of naming this disease for your enemies. The French called the Great Pox or syphilis the Neapolitan disease, the Spanish disease, and the Great Pox. The English called it the French disease, Italians called it the French disease. Russians called it the Polish disease. The Polish and Persians called it the Turkish disease. The Turks called it the Christian disease. The Haitians called it the British disease. India referred to it as the Portuguese disease, and Japan called it the Chinese disease or the Persian fire. So we'll talk about cholera. The first modern pandemic was recorded beginning in 1817, but we know that diseases very similar to cholera have been recorded from Hippocrates and Galen in ancient times. There are numerous hints that indicated a cholera-like disease was also known in India since antiquity. So again, in 1817, originating in Southeast Asia, it developed around the world. We've had 5 more pandemics erupting and receding, the last one of which began in 1961. Each one had heavy morbidity, not as much mortality as some of the other pandemics, but significant mortality nonetheless. Cholera, which is a waterborne disease, has been disruptive to trade, travel. There's often an overlay to either natural or man-made disasters, which facilitate or enable dirty water to be more prevalent. It is strained medical and public health systems, and it flourishes in those areas without good medical or public health systems. It can create famine, or has created famine, has created panic, and has impeded development. So we'll talk about Spanish flu, the greatest of all time, with no apologies to Mr. Brady. By the numbers, Spanish flu killed about 50 million people worldwide, estimated to have infected about 25 million in the United States. The number of deaths in the United States occurring because of this was about 675,000. The percentage of flu deaths age 8 or less was 20%. 1 out of every 5 deaths in the United States due to flu was in children age 8 or less. This incredible pressure and diminution of numbers on our younger population decreased life expectancy in the United States by 12 years. 50% of our military deaths in World War I was not battle related, it was the flu. There is a very robust debate in historical circles as to whether or not the quote unquote the Spanish flu ended World War I. The German forces were completely exhausted and decimated, and here came hundreds of thousands of Yanks from the United States to bolster the ranks of the French and the English and the other allies. There was no decisive battle that ended World War I. It ended in an armistice between exhausted foes. I've talked about social changes wreaked by or created by these various diseases. Curiously, you have to understand that the United States was a very different nation. It was mostly rural. The cities were not all that large, and it was not as knitted together through media or even government the way it is today. So the most I can say about diseases afterwards or impacts afterwards was we had an outbreak of mass amnesia. The Great Flu was quickly forgotten. People wanted to forget about it. It was so frightening, and on a very small scale in each town, many towns did not realize that what was happening there was happening elsewhere because there was no national media. So people just wanted to forget about it. So there were no major social changes that occurred in the US. And it may be difficult to measure social changes that occurred elsewhere because it also came with the end of World War I. So any changes might have been attributed to the devastation wreaked by that war. A few things just to look at. This is the incidence of death from the Great Flu, and you can see the first wave was in the springtime of 1918. The second wave, the deadliest wave, was in the autumn of 1918. And the third wave was after the war ended, and in the United States when the servicemen came back from Europe. And there was a very, very robust debate in the leadership circles in the United States, meaning in the federal government. Should we bring them back? Because they knew that there would be very crowded troop transports and that there would be parades, celebratory parades to honor the servicemen. And so there would be mass events. Now, there were no, the term super spreader event did not exist then, but that's exactly what happened. Both the transport resulted in easy transmission of influenza coming home, and then the massive parades that were held also facilitated the spread, a new wave of spread. So here you have the dotted line is death data by age group. The dotted line is pre-Great Flu, and then the solid line is the Great Flu. So you see what we ordinarily see with the dotted line, which is greater death rates in the very young and then among the elderly. But with the Great Flu, we had something which we have rarely seen from influenza, and that is a spike, another spike in the data, people 25 to 34. This is people in the prime of their lives. This is when they are perhaps the healthiest that they will ever be. And look at the increase in deaths in that group. It was remarkable, and like I said, we really haven't seen this since. We have had 3 influenza pandemics in 57, 58, 68, 69, and 2009, 2010. All were pandemics by definition. However, we've had ever improving response in treatment technologies and vaccines. All of these aided in reducing their impact on society. The most recent one, 2009 and 10, the swine flu, began looking like a fearsome killer. The original data, or the initial data, mostly came out of Mexico. And it was, the early data was saying, this is a real killer. But it turned out that the early data was not reliable. And this actually ended up being somewhat of a mild strain, a pandemic nonetheless, but still a fairly mild strain. The most interesting aspect was the 1957-58 strain reoccurred in 1977. Now, this is astounding. How could a naturally occurring pathogen that routinely experiences mutations and recombinations, how could 20 years later it reappear as the exact same strain that circulated 2 decades earlier? The mathematics of that are just so improbable that it borders on being the impossible. But after the fall of the Soviet Union, we understood just how extraordinarily large the bioweapon industry in Soviet Union and perhaps also in China had been during its communist era. And we're thinking that there was an accidental release of the 57-58 strain, which had not been extant for 20 years. So there was at least an entire generation that was susceptible to it, had never seen it before. And we actually had kind of a second pandemic, a low level, that did make its way around the world. But it may have been, as I said, related to biowarfare efforts, which was very frightening and very sobering once that was realized. HIV/AIDS, 1981 to the present. This is a disease that attacks the immune system of those infected. Retrospective analyses of banked blood samples indicates that HIV jumped from chimps to humans in the Democratic Republic of the Congo sometime in the 1920s. We've had sporadic cases probably occurred through the 1970s. By the 1980s, it may have been on all 5 continents. The first report was in 1981, the CDC's weekly Morbidity and Mortality Weekly Report magazine reported 5 men who have sex with men in Los Angeles with an unusual pneumocystis carinii pneumonia. This was initially called GRID, gay-related, I always fall on it. Immunity disease. I just botched that, I apologize. And a few months later, it was renamed the Acquired Immune Deficiency Syndrome. 1983, the causative virus was identified and eventually named the human immunodeficiency virus. So GRID, I'm sorry, that's gay-related immunodeficiency disease. The modes of transmission for HIV and the disease that cause AIDS were sexual transmission, drug injection, maternal fetal transmission, and blood transfusion. By the numbers, between 2014 and 2018, there were approximately 38,000 new infections each year in the United States. In the United States, we have about 1.2 million people living with HIV. Unfortunately, 1 out of 7 do not know that they are infected. So in the US, we have various disparities. Regionally, it's more prevalent in the South. The 2 age groups that have the highest rates per 100,000 are the 25 to 34 and the 35 to 44. African Americans, comprising close to 13% of our population, have an incidence rate of 45.4 per 100,000. Latinas have an incidence rate of 22.4 cases per 100,000, and they comprise about 18% of our population. And multiple races have a case rate of 19.3 per 100,000, and they comprise about 2.3% of our population. Males, 22.1 of the per 100,000 cases are males. Females, 4.5 per 100,000, I'm sorry, 22.1 per 100,000 population, and females 4.5 per 100,000 population. And the primary mode of transmission is male to male sex. 67% overall, and 82% of AIDS, HIV/AIDS among MSM is sexually transmitted. HIV/AIDS has been a game changer. It became obvious that this is as much of a social as well as a medical issue. And this is, I think, really the first time that maybe outside of medical or public health circles that this was a societal issue. This involves a socially unpopular group, particularly men who have sex with men, who aggressively advocated for funding and for a role in how the money is to be spent. This has never been done before. And in doing so, the social aspects of this disease were brought to the fore. Issues related to sex, sexual transmission. If you recall, the Reagan administration would not even talk about AIDS. I was in the health department in Massachusetts. We could not talk about condoms. We could only talk about barrier methods. People were very, very concerned about any frank discussion. So also discussions of discrimination, jobs, social services, political power, all were on the table because they were all aspects of facilitating factors for transmission of HIV and development of AIDS. This really showed the importance of clinical and social services working in supportive tandem. Oh my goodness. Oh my goodness. I've really overdone it my time. Okay. So why don't we pass the questions? Let me go through COVID-19. My profound apologies. This is an unfinished story, but we're seeing this in the daily news, the morbidity and mortality changes. And I'll talk about that. But we read, we feel, we see multiple wide-ranging social disruptions and disproportionate impacts. First cases were reported from Wuhan, China, 2019. The common factors was the initial cases all visited a seafood market in Wuhan. It's called a wet market. And this is a picture taken of a wet market in China. You can see that these are not sanitary conditions. Some people are working with gloves, some people are not working with gloves. And it came to America in 2020. The first case in America was in Washington State. The US in February, we had cases existing or soon were recognized elsewhere. There were multiple introductions into the United States. US implemented air travel restrictions from China, declared a public health emergency. The Senate ultimately passed, as we headed for a lockdown, the Senate passed the CARES Act, the Coronavirus Aid Relief and Economic Security Act. But cases continued to rise, hospitals were overwhelmed. Factors that increased the community spread and risk: crowded situations, close physical contact, enclosed spaces, inadequate ventilation, airflow in those closed spaces, the duration of contact, the lack of use of non-pharmaceutical interventions such as masks, social distancing, and hand washing. Globally, 46.2 million cases as of November 2nd. It's rapidly increasing both globally as well as in the United States. In the US, we've had 9.1 million cases, which is 2.4% of our population. 230,000 deaths, which is about 2.5% of cases. The United States comprises maybe 5% of the world population. 20% of all cases are from the US, and 19% of the deaths are coming from the US. That is an indictment of the US response. You see the disproportionate impact on different races and ethnicities here on this slide, with 61% of the cases in the white non-Hispanic population. 61% of the population of the United States is white non-Hispanic. It has seen 51% of the deaths and 44% of our cases. Black African American population is about 12.3% of our population, and yet they're seeing 21% of our deaths and 18% of our, almost 19% of our cases. And the Hispanics are about almost 18% of our population, and they're also seeing 21% of the deaths and 28% of the cases, almost 29%. These are indications of the social inequities. Well, this is basically the same story. Cases per 100,000, the greatest number of cases occur by rate among Native Hawaiians and Pacific Islanders. The greatest number of deaths, or the greatest rates of deaths, occur among our Black African American population. About 75% of our cases occur the ages 18 to 64, and yet 95% of our deaths are occurring in our older population from 50 to 84 plus. Males comprise about 48% of our cases, but 54% of our deaths. Females, 51%, almost 52% of our cases, and 46% of our deaths. You see in the first wave for hospitalizations, many more people in that first wave were hospitalized, required hospitalization, had more severe disease than what we're seeing in our second wave. The number of new cases, which is in blue, is now greater than the number of cases that are hospitalized. And I think what we're seeing here is impact on better supplies of PPEs, personal protective equipment, as well as technologies. And we've had more experience with these cases in treating them. And we have a steroid as well as an antiviral now in our armamentarium. We see the increase in tests. Testing got off to a terrible start in the United States. It has improved since then, but unfortunately there have been active exhortations to slow down the testing here, which is not helpful. It's as if tests are creating cases, and I heard a colleague give a nice rejoinder to that, which is pregnancy tests do not create pregnancies. So the coronavirus testing is not creating cases. And we see the deaths per day in the United States, and this goes along with the earlier slide on the deaths. We're seeing a reduction overall in deaths, not a reduction in the number of cases, but we're handling the clinical aspect of this much better. So why don't we just go to questions here? And I do apologize for going over, but Sue, are there questions?
No questions so far.
Okay. So if you do have questions, if you have suggestions for future topics, suggestions to improve future presentations, or any evaluation comments, here's an email that you can use and send all that in. If there are questions that come in, I will respond by email. If you want to be CC'd on those so you know what the questions were and what the answers were, then why don't you send in an email to this email address and just say that, please include me on any responses to questions.
So Paul, I think you could go back and maybe do those last couple slides, or a few minutes before one, if you want.
Okay, let's see. I'm not sure if I can go. Can I go back? Oh, I can. Okay. All right. So our ability to predict pandemics is improving, but we are working on this. More surveillance is underway for possible pathogens worldwide. We can now, this is huge, we can now sequence the genomes of the viruses very quickly and in much greater detail. Within 3 weeks of the announcement of the virus in China, the Chinese had sent the genomic map to labs around the world, and they were able to start developing candidate vaccines in such a short period of time. Lessons we have learned that non-pharmaceutical interventions, the masks, the social distancing, etc., are necessary, but they're not sufficient. We now have some meds to prevent viral and secondary bacterial infections for COVID-19. Nursing care is huge, then as well as now, for successful clinical care. We need to have a ready supply of the technologies and the personal protective equipment supplies needed, to be available when needed. Leaders of the response need to be the experts, and the experts need to speak the truth. And social fault lines, if recognized, once recognized, need to be addressed both as health as well as, frankly, national security issues. The importance of medicine and public health working together is huge. Pandemics are, as I said, medical as well as social emergencies. We need to blend the clinical response with the social response. And a focus on global health is crucial. COVID-19 happening in one place means that it's capable of emerging in all other places. So to end this, I would say that we are still searching, but we are not lost.
Well, you now have a few questions.
Okay.
Okay. I can answer one of them. One of them is, will the entire talk be available? The answer to that is yes, it is being recorded. And we will let you know how it can be accessed. Lori is going to give me that information. The question is, what are the numbers in the Upper Valley and in particular in Grantham?
Oh, hell. You probably know the Grantham numbers. The last I saw in Grantham, was it 77 cases?
I don't know.
No?
No.
I'm sorry. I've been so focused on sort of national and global.
Okay.
So sorry. No, I mean, we know that it's trending upward, that initially very few cases were in Sullivan County. And for the longest time, we were stuck, which should be so lucky. There were only like 6 cases, but we've gone much higher than that. Maybe the 77 is the Sullivan County.
Yeah, I don't think there are any active in Grantham at the moment,
Yeah,
but they are increasing in the county. That would be, I think, the answer to that.
sorry.
No problem. How about this one? Paul, do you understand the measure that is being used by Vermont to determine the number of cases / population? I've looked at the numbers and I don't see how they add up.
Well, this is completely unimpressive. I haven't spent much time looking at Vermont, unfortunately. I know that they're touted as a huge success story, and perhaps I should have been spending more time. So I will look into that and respond.
Okay. Barb wants to know, can we get control of the pandemic?
Yes, I think we can, but we have to be willing to do the things that need to be done. We need to have a unified, consistent national response. We can't have each state going its own way. It makes no sense. The inconsistencies are glaring, and you have people traveling from state to state. There's just no control over this. We need to find messaging to talk about how important it is to wear masks, to do the social distancing, and kind of take the public health measures out of the political sphere. I'm afraid that that genie is out of the bottle, but we have to figure out a way. We can't just sort of moan, oh well, damage is done. I think we have to find ways to model a more unified behavior, or more unified behaviors, and to address these issues of liberty that the political forces have imbued this topic with. So it's not going to be easy. Certainly with the vaccine, that's going to be huge. Again, vaccine has been politicized. So we have a huge mountain to climb in order to do this. But are we capable of it? I believe we are, but it's not going to be easy.
So here's a question relative to the past from Ken. Are there any lessons on pandemic fatigue we can take away from the 1918 flu to apply to the present?
Excuse me. Probably, I'm not aware of them. The 1918 flu happened over a 3-year period, and it happened during a war. So there was very little publicity about it, very little news about it in the larger newspapers. The media at the time, we really didn't have radio per se. We didn't have the national networks. There certainly was no television And the newspapers had an understanding. There was a relationship with the government, sort of a hand-in-glove relationship of yeah, we'll do your bidding because it's for the greater good. And the government asked for, no big articles about the flu because they thought that bad news would be debilitating to the war effort. Again, it was only over a 3-year period. People didn't realize how pervasive it was and how extant it was throughout the country. So it came, it killed, and it left. So I don't know of pandemic exhaustion taking place. There was no language for that, and there was no real understanding of just what was actually happening in the United States or elsewhere in the world, except for Spain. Spain was the only place in the Western world that had a free press. They were not a participant in World War II. Therefore, they were freely reporting what was going on there. So everybody thought that, oh, gee, this disease is happening in Spain. So they called it the Spanish flu. Long answer, but no.
Okay. Barb says, how long before the COVID outbreak appeared did Paul and Ken warn us that we were overdue for this disaster?
How long? It was recognized in China sometime in November of 2019. I believe that the Chinese did what they could to put a lid on broadcasting this. The physician who ultimately died from it was sanctioned for trying to get the word out. But I think within a matter of weeks, the Chinese became very cooperative. They changed their approach to this. It's interesting if you look at so many of the journals, the infectious disease, the emerging infectious diseases, etc. From January, so many of them were filled with papers from Chinese authors. So they became very good, very efficient at getting word out, and they distributed the virus so that the genomic map could be created.
I think what Barb is also saying is both you and Ken have been saying for quite a long time that we were overdue for this.
Yes, and I take no particular pride because and most people in public health were saying the same thing.
Right.
We were overdue but all of us, I think most of us were thinking of influenza as opposed to coronavirus. But there are similarities, and I believe one of our future speakers is going to talk about specifically this issue of coronavirus and influenza.
There's a couple of answers actually to the question about what the morbidity or what the numbers are here in Grantham. Duncan says that the WMUR says 11. I think that's 11 cases overall, none active at the moment, I think. And Sue says Sullivan County has 103, which is up 20 from last week. So that's a little more data for people.
Thank you to both.
Brad wonders, do you think aerosol spread is more important than droplet spread?
All of these have been really good questions. This is, there's been so much emphasis. I think my knee-jerk response is probably yes. We have spent so much time on the droplets and the 6-foot gap between us, but the aerosol can really expand that distance. And we really haven't changed our recommendations too much in terms of social distancing. I will say places like, for example, Forbes Tavern if you look at the way they've placed their tables, they have gone beyond the 6-foot distance. And I think we're seeing that in some other restaurants in the area when you walk through and you see the inside. But yeah, it just, I think we have to realize we're not as safe as we might be if we only look at the 6-foot distance. So I think our messaging needs to improve, and I appreciate that, Fred, you brought this up.
That was Brad, yep.
But Brad, I'm sorry.
Duncan's got the last two. First of all, when do you hope to get vaccinated?
Wow, that's a huge question. You know, I've been very concerned about a vaccine coming out before the election. It would be way too political, and I would not be, even if I qualified, I would not be first in line. I don't think that I'm going to be first in line, regardless of when a vaccine comes out. But I think if we can give it time for a good evaluation, I don't see getting a vaccination before 2021. I'm sorry. I just don't see it happening. And even then, for someone with my circumstances, I'm not sure I'd be eligible until sometime in the second half of the year. I mean, I will line up when it's ready, and when the evaluations have come in, and when all of the relevant regulatory and advisory committees have given their stamp of approval.
Okay, one more.
Sure.
Duncan wants to know if the virus is the same, the one that started in December, is it the same now or has it mutated to a new form?
I think there have been some mutations, and I'm sure that the vaccine manufacturers are doing what they can to take this into account. But I don't think it's like influenza. I don't think influenza, those can change incredibly frequently and easily. I think there's more stability with the coronavirus. It is something that we always have to look at, for sure. But right now, I don't think that the variability of the genome is one of the more pressing issues.
One more. Can you take one more?
Oh,
Deanna,
sure.
Deanna wants to know whether Eastman can mandate masks. In Grantham, people are supposed to wear them, but many do not. Workers come in and do not wear them. But some people here just don't adhere to the rules. How can we enforce this further?
The public health ethos is, if you give good information, most people will act on it eventually. And mandates are very difficult. I would ask, what would Deanna or anyone else who wants a harder stand on this? I would ask them, well, what exactly would the consequences be, and who's to enforce them, and how would you enforce them? And it becomes very, very difficult at that time. The mandates often create an outsized response in the opposite direction. And so I think it's important that with our messaging and with our education, and we talk about, under what circumstances are masks most important. So, would I be upset if I saw somebody in Johns Glen on the trails without a mask? I don't think so. I think we have to pick and choose our battles on this one.
The other thing I think that is happening here is Paul and Ken and a few others of the Eastman group, they're all on this Eastman Health Committee. They meet once a week, at 8 o'clock in the morning on Tuesday, to talk about what Eastman should or should not be doing. And actually, there will be another talk in this series from that group about how they tried to make the decisions that they made relative to amenities. And I think people are encouraged to bring those concerns, any concerns actually, relative to what's happening with COVID and with Eastman to this group for discussion. They're working really hard to try to figure out, what's appropriate, what's doable, what's not doable, et cetera. Would that be accurate, Paul?
Yeah, that's it. That's accurate. And we try to follow the science. And I'm not sure that the science calls for, masks in all circumstances. So, and I hope that that isn't either misunderstood or whatever. It's just that we can't go beyond what the science is telling us to do. I will say one of the things, and not to be a buzzkill on the future lecture, but one of the things we've spent a lot of time is talking about ventilation and airflow. And one of the things that I will say is that when we see the recommendations of the state, those issues are never really presented. They talk about social distancing, like reopening the restaurant, etc. We've taken that into account here in our buildings, and you don't see that when you listen to the state of New Hampshire or many other states when they come out with their recommendations. They're not getting down to that level of technicalities.
Well, thank you all. And as I said, if you have concerns, by all means, go to Eastman, and the health care group will address them. They do it every week. And as Paul said in his last slide here, if you have any suggestions for us, if you have anything to say relative to the evaluation, suggestions for other speakers, we actually are still putting this whole series together. We just thought of 2 more potential speakers today. Or if you had any questions that you didn't think were answered, or you have further questions now, by all means, just use that email address. I'm going to be the one looking at the responses with Sally. And so we'll forward anything that you want Ken or Paul in particular, given this talk. If there's further questions for him, please just email us. And with that, we'll thank everyone for participating and hope to see you all on November 20th when we look at the global situation and the WHO. Thank you, Paul, and thank you, everyone.
Thank you, everybody.
Mm-hmm.